All right, welcome everyone, and thank you for joining us for integrating AI capabilities into digital health programs, part 2. Today, we're going to be talking about building new business models for care delivery with AI and digital health. And I will turn it over to Dr. Lee.
Thank you. Thanks so much for the introduction. To the audience, thanks so much for being here. Some of you may have been to the first part 1 of the panel. So this will be kind of a sister part 2 version where we're talking about digital health, AI, and more specifically, how do we think about business models that can be enabled by these 2 types of capabilities. The first part was about the care model. This part is going to be about the business model. So really excited about this conversation. My name is Ms. Ron. I'm a physician at Stanford, faculty member in the Department of Medicine. I'm a medical informatics director for digital health for the health system. So I work with the team to lead the implementation of new digital health programs for Stanford Healthcare, which is an academic medical center. And I also help lead the Center for Digital Health, which is an academic center where we work on convening thought leadership around how we think about digital health, what the future is, have conversations like the one we're having now. And without further ado, I'll have the panelists introduce themselves as well. I know we have a couple who are actually just in the process of joining, so I'll just call you one by one and just give a brief blurb about who you are, what you do, and then later on we'll kind of get into the discussion. Parker, do you want to go ahead and start?
Sure, thanks, Ron. Hey everybody, my name is Parker Holcomb. I am currently the Chief AI Engineer at Elevance Health. You may be familiar with us as Anthem. We are the second largest health plan covering about 50 million members. In my role, I'm able to spend about half my time actually programming and doing data explanation and building models. And the other half of my time is really understanding the context about where we're operating. And so very excited to be here and chat with these awesome panelists, and looking forward to the conversation.
Thanks, Parker. Rebecca?
Sure. Hey, y'all, I'm Rebecca Mitchell. So I am currently helping to build a new care model in business for rural healthcare with a company called Homeward. And I also invest at an organization called the Vive Collective in early to kind of later stage digital health companies. But I grew up in medicine. I went to UCSF medical school, worked a lot on global health, particularly reproductive health early on, where I really learned how you build products and new care models for very different communities and people, and how to wrestle with often the absence of a business model. And since then, I've spent about 15 years in product at companies like Validic, Livongo, and Teladoc, and now currently Homeward. So I'm not an expert in AI, but I've worked with and for a lot of companies that certainly used it to make their care model possible.
Justin?
Great to see everyone. I'm Justin Norden. I'm a partner at GSR Ventures, where we're a health tech focused venture fund with a little bit over $3.5 billion under management. We focus on investing in companies, AI, digital health companies that are really using technology or new capabilities to fundamentally change how we're delivering care. So we really look for not those 10 to 20% improvements, but 2x, 3x, 10x or more improvements over the status quo. By background, I started out as a computer scientist. I did my undergrad and master's in computer science and computational biology, focused on machine learning and genomics, kind of very much on the academic side. Went to medical school here at Stanford, was part of the team helping to get off the Center for Digital Health as well, that Dr. Lee works with. Ended up going to Apple for a couple of years on the healthcare team, starting a couple companies of my own, one in the AI space around algorithm safety and trust. We actually pivoted out of the medical device space and ended up selling that company to Waymo, Google's autonomous vehicle company. And now focus on investments and working with early stage companies and really trying to help them figure out their business model. How do we take these ideas from academia? How do we take these ideas from a concept to a fully fledged business that can really kind of grow and transform our healthcare ecosystem? Looking forward to the discussion.
Thanks, Justin. Lisa?
Sorry. Hi, everyone. So nice to be here. I'm Lisa Gohill. I lead the digital strategy for Stanford Healthcare, so the healthcare system associated with Stanford. And I'm sort of new to health systems. I had spent about a decade in management consulting, working on digital strategy in healthcare largely, but primarily for pharmaceutical companies. And then spent a few years in commercial leadership roles for a startup focused on clinical research called Evidation. And so my role here is really to create the roadmap for the digital transformation initiatives or programs that Stanford will embark upon in the next 3 to 5 years. So.
And Chris?
Chris Odell, and I'm the Executive Director of Digital Health at Stanford Healthcare. And we have 2 parts to our team. One that is, as Lisa mentioned, a strategy arm that goes out and thinks about where does it make sense for Stanford Healthcare to pursue digital health. And then the other side is one that goes out and tries to get those initiatives live, which is a very difficult job because a health system is complex, and bringing any new business model or care model into the organization and protecting it long enough to stand on its own feet is many people's full-time job. And my hunch is that I've been in healthcare at Stanford for about 10 years. But that there's a lot of opportunity for bringing AI in. Frankly, we don't integrate it much into what we do today, but I think that's the discussion today, and very optimistic about what it can do for those strategies and businesses.
Thanks, Chris. All right, well, let's jump in. So for those of you who may have attended yesterday's panel, the format will be very similar. This will be very much an open dialogue. I think we're talking about, I would say, cutting edge concepts here. And I think we have the perfect group of people to represent the different perspectives across health systems, industry, payers, the investment community. So I would love for the audience, feel free to type your questions up. I'll be looking through them. I'll be focused more on moderated questions during the first half, and then towards the second half, I'll be more looking towards the questions that you sent us. And then to the panelists, I would kind of encourage you all to ask each other questions and push each other a bit. I mean, this is really meant to be fun. I'm hoping that we'll learn a lot from each other, and I think really advance the conversation forward. So what I'll actually do is spend the first 3 minutes or so doing some context setting. And again, for those of you who attended yesterday, these will be actually the same slides, but with a slightly different flair. So I'll go ahead and actually share my screen. All right. Anytime I talk about digital health or AI or really anything that is potentially confusing, where words can be used in different ways, I kind of just want to go back to the basics, like start with really simple concepts. And for me, the way I think about it is that there's the user and there's a service. And it could be analog or it could be digital. And let's just not even think about healthcare or AI for a second. It's just like, how does a user interact with the service? Chris, I know we've talked a lot about, like ride sharing, for example. So this is like, actually, I'd love to get into this example later with you. But so for example, a user in this case for taxi cabs, that's the person trying to get a ride. The service is a person driving a car who might take you somewhere. And the analog world, I mean, the interaction is basically you have to hail a cab and even negotiate sometimes and exchange money manually. And now that's very different with companies like Uber and Lyft. Digital interactions, there's definitely AI involved and very different business models. So if you just change those words from user to patient and service to healthcare provider, it's kind of the same concept. It's really just about how does the user, the patient, interact with the provider of services, whether that's myself, a physician, or other staff, or even not even an individual. How do you get healthcare? There's the analog way, which is the person comes to clinic or the hospital, we talk, we exchange information in an analog way, we deliver care in an analog way. The business models of healthcare are essentially designed around that assumption that all of these interactions are analog. Now we have digital interactions that I'm sure this group will discuss later. And the really exciting thing is, now we have these digital interactions. What are the care models that can be built around it? That was the discussion yesterday, although and today I'm sure we'll get into this a bit more, but really, the conversation would focus on what are the business models that are now made possible by digital interactions in the same way that, say, like the business model of Uber was made possible because you have an app and you have this whole algorithm and matching system in the back end that previously that just simply wasn't present, and the business model would not have been possible with a traditional, kind of cab service. And how does that lead to what we all are aiming for, which is healthier people? So that's basically, that's basically the conversation. I mean, I think we'll probably end with more questions than answers here. That's my goal. But yeah, I think that's kind of it. So let's dive in. I'd like to get started maybe just by asking each panelist to give an overview of just what your general thoughts are on this topic, any particular reactions to what we just presented, and anything else that you want to share with the audience. So I'll just kind of go in the same order as earlier. Parker?
Wonderful. Well, a lot of different threads to open up and explore here. But let's start with AI. What is AI? There's sometimes to call it AI and sometimes to call it math. The guy who coined the term, John McCarthy, in 1956, would say that as soon as it works, nobody calls it AI anymore. In the 60s, the calculator was the peak of AI. And so, when to call it AI versus when to call it math often becomes, hey, how comfortable are we with, outsourcing our intelligence or, some of our decision making to a computer? And, there's sometimes that it is appropriate to, make a prediction, and that can lead to the best science or the best math. And there's sometimes it's really not appropriate. And so, for example, when you're looking at a larger population and maybe all you have on them is their zip code, it may be appropriate to impute their race and ethnicity at a larger scale. However, in a care setting, when you're talking to one individual, it's probably not best for a doctor to show up and say, hey, it's my assumption that you are blank. And so, understanding when it's appropriate and when it's not appropriate, and where the different parties involved are going to agree that it's an appropriate use, is this delicate dance that we're talking about here, and where the business model really comes in, into play as well. So, where I've been focusing a lot over the last couple of years at Elevance Health has been at the intersection of FHIR, which is the latest standard from HL7. It's the modern data standard. It reached normative use in 2018, compared to CDAs came out in 2000, HL7 V2, which still runs a lot of the infrastructure, came out in the late 80s. Said differently, the standards that we're launching today are able to benefit from everything we learned about technology from Ask Jeeves through Gmail, through Facebook, through Netflix, and all of these, different technologies, versus the existing healthcare data infrastructure is built on a lot of these things that we're just aware of Netscape or the TI calculator. And so, we're in this age now where, a lot of these, standards are starting to converge, but they still take a long time to, make their way through the healthcare system. I've learned that the average age or the average time it takes for innovation to make its way into practice in healthcare is about 17 years. And so if you look at that, 2022 is a pretty exciting time because 17 years ago was Gmail. And so, we're not trying to get to transformers and we don't want DALL-E producing our doctor's notes quite yet, but there are some of these best practices that we can borrow from a lot of technology. But if there's a place where it's not appropriate to move fast and break things, there's two industries. One is airline scheduling and the other is healthcare. And so the standards in technology inside of healthcare require a higher level of diligence than in a lot of these kind of different industries. So where I've been focused much, if not the entirety of the last year, is around the data and the quality of the data inside of this system. inside of the larger AI space, Andrew Ng, maybe the leader in AI, he talks about we are on the path or the importance of data centricity over model centricity. Data centricity says great data, simple model equals great results versus a very complex model and kind of questionable data. And so how that connects really back to the business models is when we're looking for dollars to exchange hands between different parties, we're talking about, hey, what triggers that payment? And if we want to move away from, walk into a doctor's office and you walk out with a receipt, the code that was performed, you hand that to your payer, and we want to move away from that model, we need to find ways where we can build payment models on data. But if you don't trust the data, if it's not high quality data, you're probably not going to move towards that kind of payment model. And so the intersections and complexities of all these things are what get me up in the morning and what I think about going to bed. And it's a really, really beautiful time, I think, to be in this space. And so excited to hear what the other panelists have to say and talking with you all this afternoon.
Thanks, Parker. Rebecca?
Sure. Actually, before I give my little shtick, I'm curious, Parker, what grade would you give the data that the current business models are based on? And I ask this highly biased and looking at a bunch of companies recently trying to clean up all the claims data and attachments that come in fee for service.
There's a pretty big infrastructure built to double check this stuff.
Mm-hmm.
And so whenever I'm building a model, I like government audited data. I like building real estate prediction prices on housing assessments because it's consistent. There's a process around it. It may not be the perfect process. And so the existing data infrastructure today does have a lot of checks and balances, and it's a very mature system. And so the quality of the data is all in the eye of the beholder. It's from the perspective of the data consumer. And so, A-, the data structure is working.
Mm-hmm.
We just don't believe, I think, maybe speaking for a lot of us, think that the incentive structure with that data model is the right one that's in the best interest of the patients. So yeah, A to A- in certain contexts, and in other contexts, it doesn't move the needle.
Cool. I just love your answer because it sort of illustrates that what it required was building up a massive infrastructure around it for all of those checks and balances for different purposes. So that will be equally important, I think, in the frontier that we're approaching now. Okay, so back to your actual question, Ron. I'm going to be a little spicy, which I often am, and actually say that I don't think that AI specifically creates a new business model. I think what it really does is it unlocks entirely new ways of solving problems that then makes business models possible that weren't previously, but they're not new, right? And maybe this is best illustrated if I give my sort of 5-point stump speech that I use in every product organization I've built, every new product I worked on, every company I look at, like early founders, early ideas. And the first is, don't start with technology or business model. You first have to start with a problem that you deeply understand and a pretty consistent group of people would love for you to solve, that you have a hypothesis for how to solve. And maybe that's where the AI or a new care model design can come in. 3, to solve that problem, you're going to find a clear and consistent group of people that will pay you to solve that problem. We all know we're in healthcare, usually not the same person you're solving the problem for. And 4, they're doing it, and this is really important, in a payment arrangement that actually gives you the flexibility to try some of these new things. And I know things like value-based care, it's become a lot of the, words that have become dirty words, right? Over time, that have become overused. But whether it's that or other places, we have to find ways to create that flexibility and not continue to constrain people on how they can actually work on different problems and come up with new ideas because of how we pay people at the discrete sort of process level. And finally, they have to actually pay you in an amount that is high enough for the unit economics to work. And so we're talking a lot about new care models. So a lot of services, tech-enabled services, maybe bricks and mortar as part of these companies and concepts we're going to be talking about today. It still has to work. Like people like me, companies that I work with, we don't want to build towards or invest in typical services models of like teams at best, right? Like we really want to see technology and new payment models creating leverage so that you can make mistakes without going underwater and shutting down half your facilities, which is unfortunately happening in a lot of healthcare right now, particularly rural healthcare. And of course, you'll be competitive when you get out there in the public market. So I think like really you have to think about business models and the technology really embedded in those 5 points. And none of them can sort of be thought about on an island.
That's great, Rebecca. I'd love to get into later this concept of flexibility. And I wonder, just the question of flexibility, maybe the business model, but even I think operational flexibility, which I don't, maybe that's what you're referring to as well. And how do you have operational flexibility that allows you to try things, be a bit more resilient? Maybe that's also where a bit of AI capabilities can kick in. So a great topic to discuss later. Justin?
I think I'm really just going to build off of Rebecca's answer here. And I think it's just starting with the basics. I think, we are so excited about AI, and I think AI allows us to do some incredible things. But fundamentally, actually, I'd love to use old business models, simple business models that have been tried and true with and augmented by AI to create things going forward. Because what's really scary is, I think Rebecca mentioned, people coming with the technology first. I have an AI model that does X with Y predictive power, and Justin, once you give me money to fund this company, it's going to be amazing. And they didn't go back and answer those questions of who's paying for this, who gets value for this, ideally in a way that doesn't fit into, if I wave my hands and say value-based care, then I'll get a piece of that bucket, because it usually doesn't work. And so to me, one of the things I think that I just love to get across to this audience, and one of the things I get across when I teach to Stanford medical students and business school students and undergrads, around digital health and what the future might look like, is make sure you're just thinking a little bit about the incentives for your product and for your business. At least think of that somewhere in the development, ideally before years and millions of dollars of work or resources and time have gone into this, of who's gonna pay for this, and who's gonna use this and why. What is it gonna replace? What is it gonna change? Who is impacted by this? And just write out all of the different people who this technology impacts, and then just make sure you have clear answers. Because the best businesses, or the businesses we see that grow the fastest in the healthcare landscape, are the ones often with very, very simple business models, where, for example, a company is going to find patients, from a health system that match clinical trials, and pharma will pay, to find those patients on trials. That's it, right? There's nothing more complicated than that. And so I think that's the one thing I'd really like to push. And I think people, maybe more so in digital health and in AI, and more so than other spaces, people think it's okay not to think about the business model, because we're focused on patient, because we're focused on care, because this is good for the doctor. Then I earn the right not to think about who will pay me for this. And I think there's value, and I came from academia and love the mindset of let's only think about the patients, let's only think about the healthcare outcomes. But unfortunately, that doesn't translate to, I want to build a big company that's going to change the healthcare landscape. And so at some point, we need to think about the other side as well. Maybe I'll pause there for now, but love to dive in further to any of those points.
Justin, I think there's some really good points there about things we've been hearing over the last 20 years, whether it's been, during a medical education or from the, Bay Area. Don't worry about the business model, just focus on the user and everything else follows. And so, unprogramming some of those things that we've, been getting hit over the head with, for the right context is, I think, needs to be an active process.
Definitely.
Lisa?
Yeah, I love these comments. I'm going to touch on little pieces of what we've heard already, but yeah, so when I think about, first of all, the business model is so critically important, just to echo that. We sort of define digital transformation as having impacting one of or multiple of four components: the care model, the business model, and the technology and the regulatory or policy landscape, which is really important to not forget in healthcare. And so, and while it's true that transformation usually involves impacting or creating new, something new in each of those components, if you just change the care model, it would die and go nowhere without the corresponding business model at point of care. So when we think about our, the programs that we want to implement, we have to think about the business model almost at the same time that we're thinking about the care model. And the thing that makes it so hard, and I know this point has probably been belabored in all of the forums, but in healthcare, that really beautifully simple slide that Ron showed about, here's an end user or consumer, and here's the provider of this product or service. And you've got those two bubbles and an arrow, and the incentives are perfectly aligned between the two, right? Like for the Uber example, it's time and money. And that makes it really clear, and it makes the business model, it puts the right constraints around it to develop it. And in healthcare, you all know there's too many bubbles, first of all, and the fact that the consumer is incentivized by something different than all of those other players and how they all fit together, that basically the fact that that's not a linear thing, that relationship is very complicated with all the stakeholders, and then put on top of that I would argue that the incentives are not aligned. The provider's incentive structure is very different from the payers, from the self-insured employer or the employers, from the employees and the patients and the consumers, and so that's what makes the business models really, really difficult. And then just to, Rebecca, your point around like, this is what needs to happen in the flexible models. We think that that's, infinitely true. And all of the things you brought up make this transformation really hard to deploy at point of care. And the other thing that makes everything you said even harder is, I'm sure you all are familiar with, I think all providers right now are just, I hate using this analogy in California, but it feels like the house is burning, like we're all on fire, in terms of access and capacity and, sickness, like, epidemics, all of it, right? And so how do you start to think about how you modify those new models while you still have to keep everyone whole in the system that is currently in place? And so, it's hard. It's like, I'd love to take this simple approach, but the fact is, like, you can't take away the provider incentive during a provider and healthcare staff shortage, right? Or burnout, right? You just can't. So you have to figure out a way to keep them whole, but then innovate on the way that physicians are currently paid, which is really a structure of the time they spend with a patient. And so it makes all of this really hard. I'm just posing challenges, but I think that's, the world that I live in is, how do we solve the pain points of today? We have to be able to accrue value to all the stakeholders today in our projects and innovation. But how do we do that in a way where we're building the blocks for a potentially completely different new model that we know we need to get to, but we can't just build that model on the side in some sandbox and then turn it on and go, right? Like, so that's the struggle that I think Chris and I live with, and what makes the flexibility point just really, really important. And a lot of the things that we're deploying, I would say others might look at and not think of as transformative. And that's the reason why. It's because we need these kind of baby steps to get there, so that the system, we don't break the system.
I think that's really well said, Lisa. What they say about healthcare, you got to fix the airplane while it's flying, right? We can think about transformations, but the ED is filling up as we speak with people on needing dialysis and RSV and all that stuff, and we just got to keep it going. And I think that's one of the, to your point, unique challenges of driving digital transformation within a health system. And I think that's a really important perspective. And Chris?
I'll build on 2 points. First, I'll just start with what Rebecca said, which is in order to do any of this business model change, you have to know who your customer is. And I actually would say not most, but a lot of businesses in healthcare and startups and founders don't actually know who their customer is. So it's not uncommon that I see businesses with new business models that don't know whether they should be a direct to consumer business or a B2B2C business. And for all of the reasons that Lisa just said, that's a really hard thing to get to the bottom of, because if you want to, let's say, decouple the value chain, healthcare is so complex. How are you going to go find which part of that you're going to decouple and the incentive that is in there? And secondly, if you're going to create some product that a consumer loves, you have to know exactly who that consumer is. And so I actually don't blame the innovators that are trying to solve this problem for not knowing who the customer is, but I would say really get laser focused on that if you're going to try to change a business model, because that's at the core of the value proposition that you provide. So when I think about going back to the basics, and I will purposefully simplify this problem, but the world today in healthcare is built purely around doctors. That's really, there's all this noise in the middle, but it's all patient trying to get to a doctor. Now, I'm not saying that's how the future has to be, but if you're going to create a new business model, you have to do better than what the doctor is able to do today. And I would argue that is that the doctor today knows who you are really well. They're able to personalize their response to you as a patient. They're able to diagnose you. They're able to tell you with an accuracy that we accept today what they think you have. If you're going to build an AI model, you better do better than what the doctor can do, or at least augment that ability for them to do that. And then finally, and I think this is perhaps the most important thing, especially in US healthcare, that doctor can navigate you through an incredibly complex system that you have no idea how to navigate yourself. And so if you can kind of get back to those core things that I believe the patient is seeking from the doctor and create a new business model around that and know who your customer is, I think there's a lot of promise for how you layer AI in to enable those solutions.
Thanks, Chris. I think that's a really important and interesting point that may not be obvious to many, in the sense that, in other industries, again, I'm not an expert here, but the value proposition often it's kind of cost, convenience, right? Whereas in healthcare, of course, those are value propositions, but I think what you're touching on is this very unique value proposition that really exists in, healthcare, maybe a couple of other industries where trust, the personal interaction, but really trust, I think, is actually a big one. Maybe that's what I'm paraphrasing here. If you are able to reproduce that trust and use it to get you to feel better and be a partner, like that's a pretty unique thing that I think patients do actually really value. And, individual analog interactions actually do a pretty good job of doing, although clearly could be better. So I think it's an interesting question as you layer on digital capabilities, AI, what would be a strategy to preserve or enhance that trust, not try to replace it in a way that actually diminishes it, which actually decreases the value of your product. And I think there's a lot to get into there. Great. Well, thank you. This is excellent. I'm taking notes furiously because I think there's so many things to get into here. Before we actually even talk about AI and some of the more specific topics, I was actually wondering if we could maybe go back to just a pretty basic question, which is what exactly is this business model? We've all used this term. We've now used it many times in the first 15 minutes of this panel, and I know, and each of you have kind of given an angle as to how you think about business models. So I'm actually just curious for perhaps for myself, and I think maybe for the audience too, how would you define a business model, and more specifically, what's wrong with the business models that you're seeing? And I think I like this. I want actually everyone on this panel to answer this question. Chris and Lisa, I guess maybe one of you can, just because you're kind of representing a similar perspective here. But from the perspective of a health system, perspective of, so Rebecca, in your case, building, I would say, certainly novel care delivery systems, but still, care delivery in that sense. Parker, you're working for a payer, and Justin, you're exposed to a variety of different companies, but I imagine many of which are actually just pure software plays. These are all very different entities in the health system with, I would imagine, slightly different value propositions and business models. And specifically, gaps that, we all think could be filled. I'd love to just get your sense of, what your thoughts are. So I'll start with Chris, or Chris and Lisa, one of you, maybe just from the health system perspective. Like, what's the business model in your mind, and what's wrong with the business models that you're seeing now?
I think the business model is a combination of the customer you're trying to serve, the value proposition you provide to that customer, but it can include a lot of other things too. It can include the partner that you do that with. It can include the how you generate revenue out of that transaction. So it's complicated today, but I'll cue up that largely the business model of a health system today is to treat you when you have a moment of being sick, but otherwise to largely leave you alone. And that's one of the problems with the healthcare system in the US today, is that there's a defined business model around when you have something, how do I tell you what you have and then treat it so you no longer have it? And so if the quality's good, and Ron, to your point, you trust them, and that we can talk about the work RVU and how we value the work that's being provided and the dollars that flow between that. But let's say you do that thing, then it's done, and you go off into somewhere else that is no longer part of that health system, and you're no longer managing that patient. So the business model of a health system today is largely to treat you when you're sick. But health systems today don't do a whole lot of making sure you don't get sick, or even after they treat you, make sure that you don't get sick again. We largely leave that probably not even very well done to the payer, or to maybe a little bit to your employer, or largely on yourself to do that part of the business model.
Thanks, Chris. Rebecca, so how do you think about this as someone who is in an adjacent, but slightly with a slightly different perspective, building companies in care delivery, but with a different angle? How do you think about what a business model is, and what are the gaps and potential opportunities?
Yeah. So while adjacent and different, agree with everything that Chris just said. Maybe the things that I'd build upon there were, understanding, like he said, who you're selling to, what's the value prop, why are they buying, and then how you're going to get paid, both in the sense of literally how are the kind of numbers going to move from their bank accounts to yours, and but how can you do it in such a way so it's reliable and ideally recurring, and not only profitable but margin enhancing. That to me is a real business model, not just a kind of scraping by situation. And then really starting to think forward in your business model to how that client is going to become even more valuable to your business over time. So how are you increasing lifetime value by greater share of wallet or reducing churn in your client base? How are you expanding into adjacent clients that are similar or maybe pretty different, but where the value props kind of overlap or are the same? And I sort of think about that full spectrum when I'm doing business model analysis, both for product work and for investment work. And so I think to the second half of your question, places where I see things really going wrong, it's kind of like the inverse of all the things that I just said and maybe that Chris said. So not to belabor each individual point, but more than anything, I think I see a lot of skipping steps into the latter half of the decisions to be made, instead of, I think, coming back to what Justin said. It's look, you really have to get those first few things airtight. You really understand your client, you really understand their problems, you understand that what you're solving is not a vitamin, it's a painkiller, particularly if it's a healthcare system in this particular point in time. And that's probably true of the entire market and industry, regardless of who you're selling to, direct to consumer, employer, whoever it is. I see a lot of companies not thinking enough about, prioritizing the recurring nature of a revenue stream. And when you start modeling out the types of numbers that really matter to the private and public market and really to the sustainability of your business, there's a lot of risk there if you're not figuring out how to, continue to fill the pipeline of more users and patients, if you're being paid from more of an encounter perspective. Or getting that recurring payment on a person who's going to stay with you for the long haul. So those are some of the big ones, but again, it's kind of the inverse of all of those where things can go awry. So I think if you get those fundamentals, you've solved for the 80-20 of where people mess up.
Thanks, Rebecca. Yeah, I think the concepts of lifetime value recurring revenue or monthly, annual recurring revenue. I mean, these are concepts that, I mean, Chris and Lisa, if I were to imagine in a health system, we think about them somewhat differently. I mean, in many ways, the operational mechanisms that we build to enable, say, like, I don't think we even use the word lifetime value, but whatever, something that's comparable, especially if your business model is around just treating episodic events, it just doesn't fit with, like, a concept that probably in the technology world, it's all about just like keeping people within a community and kind of, deriving revenue on a regular basis. So just something I'll get into a bit later as we get into, especially I think as we get into the operational aspects of how these organizations are run, flexibility to Rebecca's point earlier, how that could play in, and ultimately how AI and digital can maybe enable some of these things, just to give you a preview of what's to come. But before we do that,
real quick, I want to add one other thing that Rebecca said, which is I thought Rebecca's description did a really good job of showing why business model is not revenue model. We often describe those two as the exact same. Business model is much more complex than revenue model. Revenue model is just how you get paid for the thing you're doing. And there's a consulting quote that gets used way too often, but it is this concept of if you build a better mousetrap, the world will beat a path to your door. I think that really applies in this example, because if you create something better, my hunch is that the world will still beat a path to your door, regardless of how you pay for that. Like, we just need to be building better mousetraps, and that's the customer and the value prop piece that Rebecca's talking about. So I want to just highlight that, because it's really important that we don't think of those two as the same.
Well said, Chris. Parker, you're in a payer organization. I know you primarily work in building technology, but I'm curious, as you're thinking about the products you're building and how you're thinking about the value propositions of the products you're building and the technologies, like, what do you, like, as much as you can say, like, what are some things that are on your mind in terms of how does that contribute to the business model of a payer organization? And back to the same question I asked earlier, like, where could it go wrong, and where do you see the opportunity?
Yeah. So I do love the straight lines you drew before between like these two organizations. But as Lisa, kind of pointed out, payers are not a monolith. We'll talk about when do I work for a plan versus like who's the actual payer, right? It's not just patients, providers, and payers. There's plans and other kind of points. But in total, like all of these business models or approaches are not a monolith. I mean, healthcare is so huge. If US healthcare was a country, it'd be the 4th largest country in the world, slightly around the size of Japan. And so, you don't start a Japan company, or you don't solve like, Japan business. You have a customer base, and you solve a problem for distributing auto parts in northern Hokkaido. And so, generalizations on average are wrong. And so if you try to solve everything with the same, kind of approach, you're probably not going to get that flywheel that you're looking for. And how I think about the, kind of the business model, or, hey, when we're looking for, something that's going to continue to roll, I think about the feedback loop. Hey, can we get this thing into a virtuous cycle where 1 + 1 = 3, and we can share somewhere between 75 cents and 25 cents, or 50-50, or 90-10. And so, there are sometimes that there are organizations that are the scale of, nation states that can provide security across the country that, an individual couldn't, kind of reach, themselves. And so there's also 100 years of ingrained processes and behaviors that are, have led to the topsoil that we have today. And acknowledging when it's important to correct, call it I want to say sins of the past, but the choices of the past that we made for a lot of reasons. Like, hey, when should we try to dig down, 100 meters and change around the bed soil, versus like, when do we just build a drone, right? And who's willing to pay for a drone? And like, hey, those were, some problems, but we don't really need to, kind of solve that, in order to get to the kind of the piece where we want. And Steve Jobs would say that he is as proud of the things that he said no to as the things that he said yes to, and innovation is saying no to 1,000 things. And so when you get pulled into a conversation, hey, can AI automate that? Yeah, of course we can automate that. Question though, should this process even exist in the first place? And so like, yeah, there's some really powerful tools, but pointing it at the right vector, getting it on the right direction, and not trying to fight through or to try to say, hey, you 50,000 people over there, you're doing it wrong. Look how fancy this technology and powerful this kind of like technology is. It's like, well, hey, are there 500,000 people that way that I can help? So finding the right vector to go down can make all the difference.
Yeah, that's really interesting. You know, something I'd love to get into with you a bit later is also this idea of, well, again, I'm making assumptions here, but I mean, Elevance is it's a large company with, you know, lots of customers, ongoing operations. In some ways, I think back to Lisa's point earlier about having to just keep the operations running and humming while thinking about innovation. I'd love to get your perspective later as well as how do you do that? How do you innovate while keeping things running? But also, how do you maybe even derive some of the experiences, the cumulative experiences from the ongoing operations, which in my mind is actually kind of an asset. We may not think of it as that, but it is an asset. Like every new interaction you already have with a customer, that's an asset that like a new startup won't have because they just don't have that. Is there a way to turn that into an asset that can actually drive the innovation process? Just something to kind of put in the back of your head until, they might get into it later. And also back to Chris and Lisa might think about this in the health system side too. Great. And Justin, last but not least, so you have a vantage point that's interesting. You look at many different companies across payers, providers, pure software. I actually would like you to comment more on that the pure software plays. Like you even mentioned an example earlier, clinical trials matching, right? These companies with business models that are kind of, that you plug into the system, transform in different ways. One, what's your reaction to what's been said so far? And two, just thinking about these pure software plays, same questions, what's the business model and, where are the gaps, where could go wrong, and what are the opportunities?
Yeah, so I think it's really important again, and I think one of the fun parts that we just did is we highlighted, what's the business model for a traditional healthcare system. We touched a little bit, what's the business model for a payer? What's the business model for some of these newer aged, healthcare startups? And then, let's talk about it. So I want to just like maybe walk through a super simple example of, what's a business model for a startup, sells any AI or digital health solution on kind of a simple example here. So again, so business model, right? Like, the exact definition, because I don't think we've said it exactly yet. So if you look at Investopedia, like a company's plan for making profit, right? So Rebecca talked about this before. So how, I'm starting out a company, how am I eventually going to make profit? So, one of the easiest ways, again, and this will be actually pretty general, and then over the course of the discussion, I'm sure we'll get more specific, is, I want to sell a software solution. Let's say I want to sell it to Chris and Lisa over at Stanford. One of the easiest ways to get Chris and Lisa to say, yes, we want something is, let's say for healthcare, obviously it has to be good for patients, has to be good for our providers, but the easiest way to get it through their finance team is to say, hey, Chris and Lisa, this is going to make you a lot of money. And sometimes it feels like a dirty thing to say in healthcare, but it's actually one of the most effective ways and ways that healthcare institutions across the country make decisions. Will this new investment in new piece of technology make them more money? It's probably the easiest way to get a purchasing decision done. You also need to provide clinical value, patient value, all these other things. But for the business model discussion, let's talk about, you need to make them money. And so if I'm going to make Chris and Lisa, let's say, $1,000 for every kind of unit of what I give them, then the simple way to think about it is in general pricing, I can capture about 10% of that. So if I say, Chris and Lisa, you're going to give me $100 and I'm going to help you you're going to use my tool to generate $1,000. That's kind of a rough example of how much you can charge for that piece of software. And as Rebecca said before, I better be able to do that for less, right, than that $100. Because if I'm going to get paid $100, ideally, if I'm software, I hope to be able to do that for call it around $10 to make sure that works. So right? The simple math for $10 to $20 of software cost or customer success and people to help out with whatever algorithm or digital health solution I'm going to be generating, I need to generate roughly $1,000 of value to my partner. So let's walk through a more concrete example, but like that's just a simple way to kind of think about these steps for a software business. We can look at these companies that did remote patient monitoring. So what happened with remote patient monitoring? CMS a few years ago created these new codes to incentivize people to be do care at home, to kind of have more touch points with their clinical team, because there's enough papers and academic research and other information and just general knowledge that, hey, if we touch patients at home, we can keep them out of the hospital, improve their chronic conditions, get them into a better state. So what happened? Now there was these new codes that said, if you're monitoring patients at home, monitoring their blood pressure, other vital signs, other things like that, CMS will now pay, call it Stanford, more for those codes and care that they delivered at home. So then what happened? A bunch of startups said, hey, we're going to create some new software solution that helps you kind of take care of these patients at home. So then they go knock on Chris and Lisa's door, say, hey, Chris and Lisa, you should use our new remote patient monitoring software platform. It has some devices maybe that they'll send to the home too, and we'll help you take better care of your patients. You'll get to bill more money because you'll be taking care of these patients in a new way, and we'll capture a fraction, call it 10% of that revenue. So again, this is just kind of wanted to walk through a super concrete example, but this is kind of how you can think about a very simple way to start a business in healthcare. Now, there's a lot of ways this goes wrong, which we can get into later, and a lot of ways where if that's the only thing you're focused on, that option actually doesn't work in healthcare. You better be sure you're delivering good outcomes, a good experience, all of that across the board. So actually a lot of companies went wrong doing this in remote patient monitoring, but maybe that's just a simple example. If we want to, we can come back to.
Justin, I actually love that example. If Ron, you would let me say a couple of things to build on it, because when the codes were initially released, there weren't enough, and the reimbursement wasn't high enough for the businesses to actually work. And so you actually saw a bunch of companies started or internal programs that went sideways or failed on the initial go round, and then additional codes were actually released with higher reimbursement levels, and now it's a much more viable business model. So I think it's like an amazing example of the correction that had to take place so that the hospital systems, the clinics, and the vendors could get to those numbers where they could be competitive amongst their peers working on other problems. Super interesting.
Agreed. I mean, the remote patient monitoring is actually I'm glad you brought that up, Justin. It's actually a nice way to pivot to this next section of this panel, which is, thinking about that, AI, layering AI, how do you enable new business models? Because, for RPM, it's interesting because it's, this is my opinion, but it seems like this is an example where you had a technology and then the business models were built around kind of an existing structure, in the sense that, physicians bill for encounters, so we should just have a technology bill for an encounter, and that's how you make money, right? And obviously there are limitations there. Whereas I think now more and more, even within our healthcare system, others, and certainly in industry, you're thinking about, okay, well, RPM, you certainly can generate revenue from the code. We're not going to not do that, but can we use that technology to just create, for example, more flexibility in how we deploy care? That builds resilience, that allows us to generate more revenue. But at that point, it's not about the RPM anymore. It's about that overall care model that you've now made possible, because now you have a distributed care model. And then can you create a subscription service that now gives you recurring revenue versus just purely episodic encounters and depending on that to make money? So that's just again, some more context setting for what I'd love to get into. And then we haven't even talked about AI. I mean, RPM is not AI per se, but of course you can think about layering on AI. I'm actually just looking at one of the audience questions here, which I don't think we'll answer directly now, although hopefully we'll kind of get into it. The question is actually, how do we reconcile the tension between payer and provider misaligned incentives in the implementation of AI tools and care delivery? Will payers lead the way? You don't have to answer that question, but I do think it's a nice way to set the stage for, just this phrase of implementation of AI tools and care delivery. I don't think we've actually talked about what that is yet. I think we've done a good job setting the stage for what a business model is, what's the landscape. But yeah, since this is an AI conference, I'd love to get into what are some specific examples, or how do you think about examples of AI creating these structural changes. And again, back to Rebecca's point about flexibility, how do you maybe instill this? And this is also the fun part of the panel, because honestly, you can say whatever you want. Nothing, this doesn't mean that, it'd be great if you had examples, but even if you didn't, it's really just a way to, have the audience learn how you guys think. Maybe just to, going back to the basics, I just, whenever we deal with words like AI, digital, I just like to just be very simple about what we're even talking about. And Parker, I think you gave a definition earlier for what AI is, and I'll just kind of build on that a little bit. And I think what we're all talking about when we use the letters AI is, we're pretty much talking about machine learning as the core capability, and we're talking about software that uses data to generate insights that may be comparable to what the level of insight that a human can generate, and using machine learning as kind of the computational tool or methodology, if you will. And generally, you could use machine learning to generate numbers that make predictions. You can use machine learning to categorize different things into different buckets. And now with generative AI, which is kind of a cool new thing, you can use machine learning to generate content, either generate new images via combinations of pixels, generate text. So that's kind of opens up a whole new thing. So these are like the core foundational capabilities. What I like to get into is, let's say, imagine we can do those really well. With data that, according to Parker, is actually pretty good in healthcare to an extent. What are some of the structural changes you can now think about that addresses some of the gaps and challenges you just all described in your respective business models? Parker, I'll have you go first.
Awesome. Well, a lot of ways to take this, but what it does, I think, allow us to do is kind of question some of our core assumptions. And it's often to help think about the extremes. And so today, maybe in a clinical setting, a doctor sees 10 or 20 patients a day, but what's the theoretical max? Or where should it be? Is it 30? Is it 2? Is it 50,000? Because a system it becomes so trustworthy that we need one person with extreme medical training to look at the 3 outliers out of the 50,000. And so the different parts where that is, again, going to become normalized, and again, back to a definition of artificial intelligence, is any system that emulates human intelligence. But what is human intelligence? Like, podcasters and philosophers have been talking about this for millennia, right? And we can't even agree on that. But some of the best questions to ask in this partnership is, what do you want the AI to do? And what do you want the human to do? And when you look at more concrete examples, it becomes a little bit easier. Well, I probably don't want the AI writing my referral notice and the outcome letter. And I don't know if I trust that. And the doctor themselves are probably not going to trust that. They still, they have their credentials and they're in the system and they're experts for a reason. So that's probably not something that is going to be, folks are going to be open to leveraging. But if you think about in different contexts, I think one of the, call it AI implementations that I thought was the right simple tool for the job. Prior to Elevance, I was at a provider. We were doing in-home care plus virtual care. And we also layered into PCPs to provide supplemental nights and weekends, and also, kind of like peak times. And like many other folks in 2020, we had built our virtual care platform. But one of the best uses was wait time prediction. Like, how long am I going to be sitting here waiting to see the next person? Anyone who's ever lived in a city or New York or been on the subway, if you're sitting there and you don't know when the subway is going to come, you're super frustrated. But if there's a sign there that says 2 minutes or 9 minutes, or 11 minutes, at least you know. And when that train shows up in 11 minutes, it builds trust. And so when you can make a promise or make a prediction and then follow through on that promise in a way that everyone can believe and understand and experience, that starts to create that flywheel where it, you know, takes some of these machine learning techniques where we just think about them like a calculator. So there's places where the frictions are just so high for good reasons and for bad, and trying to fight that battle. There's the 80-20 rule, the Pareto principle, where the first 80% of the output comes from 20% of the input, and the last 20% takes 80%. Well, in software, it can often become, in a lot of other areas, it can often become the 99-1 rule, where that last 1% of polish takes Google scale power and, you know, hundreds of thousands of people to get to that last 1% polish. And if you're just working on flying cars, trying to say, hey, I'm going to solve everything with this one replace a doctor algorithm, that's so far off in the diminishing returns, when we would just love when can I see the doctor. And the last thing that I'll say is to maybe double down. I think Rebecca is quickly becoming the most quoted person of this panel. But hey, when is it a technology company, or when is it a technology enabled service? It's when you're doing something with technology that wasn't possible before. And if you can find a way where the standard of care is you see 20 people a day, but you found a way to see 50 people a day, well, that wasn't possible before. And maybe you're doing that with dynamic matching, because sometimes a person only requires a 2-minute follow-up and not a 17-minute follow-up. And all of a sudden you can see that many people over a 15-minute period, instead of 3 people were blocked out over the hour, 1 canceled, 1 went over, and now you only got to see, you know, one or two people. So finding the simpler ways to kind of get started. There are so many low-hanging fruit. And if we can lean into simple language, like, you know, it used to be called statistical learning, now we call it machine learning, and, you know, it can be AI in different contexts. But finding tools and approaches that we can, number one, trust, and also number one, understand, is what gets us more familiar with, you know, repeatedly using these kind of tools in our everyday lives, business, and care decisions.
That's great, Parker. I really especially like what you said about challenging assumptions, which is a interesting concept in the sense that even if we don't have specific examples of, let's say, an AI implementation, even just understanding what machine learning can do, and then just challenging internal assumptions about operational limits, that alone might actually have effects on how you build your business. Lisa, I'll turn it over to you. I mean, you know, as you're thinking about scoping new initiatives for a health system and probably challenging assumptions all the time, how do you think about then, you know, examples of how this capability could help? And Dora, you don't have to say the theoretical limit of how many Stanford physicians, how many patients at Stanford physicians.
Get myself in hot water.
Be, you know, but I'm curious, you know, what are some assumptions that you see yourself challenging?
Yeah, it's interesting. I've been reflecting on your comments, Parker, and I guess I've just trained myself over the last year that I've been doing this work to not think about AI and ML as replacing human intelligence, though that may be the technical definition, but rather just supporting us, supporting humans, right? Like when I work with clinicians to do my work, and actually, you know, shadow folks like Ron in the hospital, I am just smacked over the head by how hard it is for clinicians to do what we're asking them to do. I mean, they've got to know your family history. They've got to know the episodic history of what happened. They've got to know all the drugs that you've been on in the last X years. They've got to know your food security situation, your housing security situation, your transportation, all these things factor into the clinical decision at point of care. And we do not make it easy for one person in the 15 or whatever minutes they have with a patient to figure all that stuff out. So I think about AI as something pretty simple, as like, how do we serve up all of the information that someone needs to make an informed decision with their training? And that's the opportunity that I see. And of course, that leads to, the predictive elements that I think are really where we are, in the provider world, when it comes to ML. It's like, how can we predict these things are going to happen? Because with large data sets, we know that there are these correlations that, frankly, a clinician who's been practicing, X number of years probably has all those things in their head. But with data, like, you now know all of the social determinants and how all of that marries into this mathematical equation that gives you a risk score. So I think about it more as that. And like, if there was I'll save that comment for later, but that's basically my thoughts on it.
Great. And Chris, I'll go back to the example that I know that we've talked about, at work, but I think I briefly mentioned at the beginning of this panel, which is this, like, this comparison of, or this analogy of Uber, and how that transformed using a cab and transportation, and how we may think about some of those lessons in supporting potentially newer business models or interaction points for health systems, where, certainly there's a lot of data and potentially AI involved. So could you get into that a little bit?
Yep. So maybe I'll do it in the context of the example that Parker started, which is of a referral. And when I first started it out, I said that the three things the doctor provided are: they know who you are, they know what disease you have, and they know how to navigate you through a really complex system. So if I were to apply AI to each of those, knowing who you are is a lot of what Lisa just said. It's about using, let's call it ML, to dig through all of the medical record and put that right at the point of service, so the doctor can say, oh, I have a much better sense of who you are. I don't have to go replicate all the stuff the last doctor did to know what I need to know about you: history, medical decision-making, et cetera. The second would be diagnosis. And I actually think we're not applying a lot of this in the care setting, but it's very close. So you can apply deep neural nets over images to help with clinical decision support. You can use, AI to go crawl through all of the claims history and say, patients who look a lot like you got these treatment protocols. So why don't we use that to inform what we're going to do for you? And so I think it can augment that diagnosis piece. But to answer your last question, Ron, about why this looks a lot like Uber, I think everyone says, like, we're the Uber of blank. But actually, this example of referrals feels a lot like Uber to me, because it has a supply-demand imbalance aspect to it. There's a lot of people looking for a very limited thing, and that creates really weird market dynamics. And so if you can be a supply-demand aggregation platform at the middle of that, saying, who are all the people looking for this thing, and how do we get them to the people that can offer this thing, and rationalize that in a way to say, hey, you're better served here, or yeah, we'll bring you in and we'll fast track you. That's a very powerful place for AI to be. And I actually don't think anyone's doing that, but it reminds me a lot of being in San Francisco like 12 years ago and calling the dispatch for Yellow Cab and then being like, are you going to the airport? No, hang up. It's like, that's basically what we're doing to patients today, because we have so little capacity to treat them. So they're bouncing all over the place.
Thanks, Chris. It also reminds me of the time when you had to like haggle for cab fares, right? I mean, that just doesn't really happen anymore. Yep. Which, obviously is still the case in healthcare. So Rebecca, on to you. Love to hear your perspective here, and even just more specifically back to your point earlier about building in flexibility in the business model and in the product and in the company operations itself. One, just could you expand on that a bit? And two, just hearing what you've heard about the different opportunities that machine learning AI could bring. Where do you see some potential use cases?
Sure. Well, I mean, I think there's a bunch of different things we can talk about that are super tactical when it comes to like the operational team and like how to do the work, how to organize the work, so it remains flexible. But I think the thing that really matters is way upstream to that. And that's just like a sufficiently sized and shaped envelope where you even can design something that looks really different, gets very different results, and can be that flexible. More than anything, we have to shift, like come back to the business model, since that's what this session's about, right? Like getting paid in a billable hours sort of concept where it's fee for service or some sort of proxy on that through RVUs, into getting paid for the total value that you are delivering, certainly to a client, right? But even more than anything, the total value you're delivering to a patient, their family, and all the people that work inside these healthcare organizations in such an important industry. And that is not easy, right? Like there's like the latest flavor of trying to pay for value, but this is a thing that we've been chipping away at for like decades now. I mean, I was at HHS, like really ONC, the I don't even know what the acronyms were, Office of the National Coordinator for Health IT, like 10 years ago when I first got out of medical school. And we were spending so much time talking about like the quality metrics and indicators. So like the carrots and sticks were actually the right ones to pay for value, right? So there's a lot of infrastructure there that needs to be built up around the business model and inside the companies and inside the health systems to really do this, right? Like you need to have a mutual agreement on what value even means and how you measure it. You need to have the ability to actually attribute the creation of that value to the right person in the value chain. And the reality is it seldom belongs to one person. It's a whole orchestra of people working together. I love the example actually of, like care navigation. There's these growing care navigation companies. If somebody ends up at a center of excellence for a total knee replacement and there's a great outcome, was it their PCP that didn't refer somewhere else in the first place and supported that kind of like eventual place where they received the procedure? Was it a care navigation company that was like calling the person, trying to route them to the right place? Was it the center of excellence? It was all of them, right? And it was the patient, right? And what they did and how they participated. So that's actually one of the hardest, thorniest parts of this. And then finally, like you could get all those things right, but is the situation still set up where your client is recapturing some of that value created? And can they share it in such a way with you where it makes the numbers right? And some of the examples that Justin gave earlier. So complicated, and we're really far from that now, but I'm really bullish because I see more companies and partners at places like Stanford every single day trying to figure out how to make this work when there is a better mousetrap, so you can pay people for having a better mousetrap that's delivering better value, even if the CPT code or whatever you can draw doesn't currently reflect the value being created.
Thanks, Rebecca. You mentioned the term value chain a couple of times, which I love, and we talk about this a lot too as we're thinking about how you might insert a technology, because I think back to what you said earlier, it's not about the tech, it's not even about the business model, it's about, are you actually solving for something that's not cared about? And a value chain is a good way to visualize that, at least what currently is happening, and where are you actually losing customers or losing value because of some process that just kind of sucks, but it's just the way it is, and you get leakage. It reminds me of this is a research project, but there was a machine learning model that was developed, I believe, by some researchers here at Stanford, actually through the Amy Center, which is the center that's hosting this conference. And basically what that model does is it looks at CT scans and it calculates the coronary artery calcium score. So for the non-clinical folks here, basically what a coronary artery calcium, or CAC, not cost of customer acquisition, but CAC is in coronary artery calcium. It's basically just a score that is somewhat predictive of your risk of developing a heart attack. And it's been kind of operationalized. It's in guidelines, and there's guidelines for how you actually screen for coronary calcium when your risk is somewhat intermediate. And that could be helpful because it might affect your doctor's decision to, say, do a coronary catheterization or some other diagnostic, all to prevent a heart attack. So the problem is that for that scan to be read, it's actually somewhat difficult because of, imagine you do a CT scan of your heart actually beats. So it's a dynamic process. So there are special protocols for how you would gate the coronary, that CT scan, and how you would read it. And it actually turns out that only a couple of specialized centers in the country can do a good job reading coronary calcium scans in CT. So you've got this screening test that potentially could be very helpful in preventing heart attacks. You can only do them at Stanford and some other specialized centers. sure these centers charge a ton of money for them, and also that they're very like kind of enclosed. You get this value chain where patients have to drive to Stanford, they get value from getting the scan, and then they have to pay for it. Obviously, that's the value of Stanford, and then so on and so forth. Well, it turns out that in this case, the investigators trained a model that actually can just look at regular CT scans and calculate coronary calcium to a reasonable degree. Now, this is all early stage, but let's just hypothesize for a second that this actually could get better. Now you theoretically have this ability for AI to generate coronary calciums from a CT scan that you can get anywhere. It no longer has to be at Stanford, it could be at your local kind of radiology center. And then the value chain completely shifts, right? Imagine if you have that, then you actually have, you kind of like disintermediate this center that these like specialized centers have. You actually now democratize, you distribute it out to the community. And think about all the different business models that you can now create that previously just was not possible because you didn't have this, because the skill set was concentrated within a small group. Anyway, all of this is very early stage. It's in the realm of diagnostics. So, as a physician, I definitely support very careful, evaluation of how these things work. But just an example of how AI can actually fundamentally change the value chain by just democratizing, if you will, by distributing the kind of the care, the interactions that previously had to occur within a couple of specific areas of the country. Anyway, I'll get off my soapbox here. So Justin, same question to you, but also with a specific addition. One person in the audience actually asked, this is kind of a good question, I guess. Like, are investors patient enough, you think? I mean, a lot of this is going to be really hard. I mean, it's going to take a long time. Do you think there's enough time for the investing community to really get into this and wait it out?
So yeah, let's start with that question, and then we can get to some of the other business. But yes, so actually we just released a report on 52, in some cases 53 digital health investors on just, are they still interested in investing in digital health? What will digital health investment look like in 2023? And the short answer is yes. People still expect in 2023, I think 70%, 71%, believe that between $15 billion to $25 billion will be the investment amount in 2023, which doesn't match our peak necessarily in 2021 of kind of this peak hype, but that's a good chunk of money, funded towards, digital health startups and startups trying to do this. Yes, healthcare takes longer than, let's pick on something, blockchain, to see a return, and or not, for that matter. And but the opportunity is massive, and so the opportunity, right, the $4 trillion, size of Japan, I think, as Parker was mentioning, healthcare spend, roughly half of that, from a lot of studies have shown, is waste. And so this isn't the case that in healthcare we're shooting for 99% and pushing that to 99.1% efficiency or something like that. There's massive opportunities. And so, yes, I think, some investors who came into digital health probably aren't patient enough, but I think there's a large group of investors, who are. And, when you have people who are coming from healthcare, understand healthcare and how long it will take, there are people interested in this space. Just to touch a little bit on the other points around business models, I think, where we get excited about kind of AI and healthcare and how it's eventually going to change the payer provider dynamic is, it's not going to be all at once. As much as I would love if ChatGPT just like solved healthcare today and, broke it wide open, it's not going to go there yet. And I think it's not going to go to AI completely making decisions on their own. So I'm much more excited about where AI is augmenting physician or other provider workflows and augmenting processes, and not trying to go to that 100%, perfect diagnosis all autonomously, because actually that last 1 or 2% or 0.1% is extremely hard for AI. Where are those edge cases? How do you find them? How do you prove safety? This was an area I worked on, a lot in the past. And so where can your AI model, get you 90% of the way there, 80% of the way there, and then use the existing system in an efficient way that fits in a workflow to 2x, 3x the capacity that they're able to see. And so how that works in a business model, take some of these companies, trying to do asynchronous telemedicine, where, they're just going direct to consumer saying, hey, forget using even your insurance. We're going to be so cheap because we're going to use AI and other tools to screen better, present the information better. A doctor's going to be there making the decision, but we're going to have our doctors make 10x the decisions for what they would normally do in their 15-minute visits or however many visits they can do in a day. And so that's an example where AI doesn't fundamentally break all the business models at once, but we're augmenting physicians in a way using, I think, Lisa mentioned this before also, we're giving the better information because there's a lot going on, giving, maybe we give our confidence of the right answer and what we think needs to be done. The doctor can make that ultimate decision. And we've just improved efficiency so much, we've bypassed the payer completely. And we've said, hey, we're just going to do this cash pay, direct to consumer. And so these are areas where that's starting. And as our models get better and improve over time, eventually, years down the line, it'll start to look different and people will start to pay for more value and other things like that.
Thanks, Justin. Just saw a question from the audience. Is there a role for AI in community-based care where GPs, pharmacists, and nurses are part of a care team? I'll actually just go ahead and address that really quickly because this was something we actually talked about yesterday, and I think actually kind of loops back into the conversations we're having now, which is how would you create new care models that could be made possible by AI, which I think based on what we're all saying here is actually a necessary step in maybe enabling some of these new business models. And one thing we did actually talk about yesterday was how, if you have AI, you have some objective adjudicator of some kind of like something that used to maybe only exist within a physician, you can actually start to build new teams. And we actually did this. I led a project doing this at Stanford where you kind of lead this, you create this new team-based care model with nurses actually being able to, come together with physicians and be empowered in a way that wasn't possible before, because now you have this AI model that alerts both at the same time and gives the same information to both parties. And then you create this kind of democratized system where you allow for interactions and conversations that previously was very difficult or maybe not even possible because of intrinsic hierarchies. So to whoever asked that question, yes, I think that's actually a huge part of it. Of how can we use AI? So how do we use the digital interactions that now can connect, let's say, a physician, a specialist at Stanford with a community physician or even an NP or a nurse in the rural area? Like that's now possible pretty easily, whereas before the patient has to drive over here. So that's actually pretty well tested tech. How do you use AI to maybe make that interaction more scalable and add some more intelligence to that interaction, or even democratize decision making to a bit? Like I think that's actually I do think that's something that we're building on that will be possible very soon. And then given let's say we have those capabilities, how do you create these new business models that we're all talking about? So that's kind of my lasting question / ask / challenge to the members of this group. So with that, I'm going to actually just turn to all of you back again and just if you could give a quick 60-second, 90-second closing statement, like what are your main takeaways and what do you want the audience to take away from this conversation? So I'll start with Parker.
This is going to be a process. It's going to evolve, and there's going to be many different players who keep each other honest. As we create a new business model, we want to try something, we want to get it started. But I want to share the lesson of the Cobra effect, not Cobra, the health insurance, but this comes from the time of the British rule of India. They thought that it was a good idea to try to get rid of cobras. And so what did they do? They started offering $100 per dead cobra. And so what did people start doing? Breeding cobras. And so as we think about the incentive structures that we create, whether it's launching new CPT codes or hey, let's integrate this kind of new outcome based off of this new technology, we have to continuously check in and say, hey, now that there are all these startups doing XYZ because of a new opportunity, how does that update the dynamic? And so I hope that we can all, get more familiar with, these types of cycles over our next, 5 and 10 and 20 and 50 years in this industry, as we, welcome some of the opportunities that these technologies can unlock.
Thanks, Parker. Rebecca?
Thanks, Parker, for that nightmare tonight. Go press through in India. So not the Cobra thing, but I do like other things Parker has said today, as well as Justin, like really speaking to how this can be a particularly like iterative journey in bringing AI and other new technologies more and more into our day-to-day work and the overall kind of experience in healthcare. And I was just, when they were talking through it, I was thinking a lot about my personal journey with like my own personal vehicles. And I grew up in a family that like never ever buys anything new. It's like a point of pride. But I did for the first time recently, because there were like no used cars on the market that were available for reasonable prices, right? Bought a new car. And I'm not ready myself yet to be in a fully autonomous vehicle driving around, but it was the first vehicle I've ever owned that had such a high level of driver assist that I immediately got it. And I saw the future of where things were going. And I was like, oh, I'm going to get there. And like really feeling enabled to spend my time differently in a car, to like use transportation differently. And it's going to be great. And it's because it was doing things like nudging me back into my lane. Turns out I'm actually terrible at staying like well within the lane on Highway 101. Sorry to all of you in the Bay Area. I'm terrible at backing up a car. Like there's all of these pieces that is absolutely leveraging all kinds of advanced technologies, including some AI, to make me better as a driver and to make my commute more pleasurable and the whole highway safer. I think the same thing's going to happen in healthcare. We just haven't had that, aha, this is magic and I love this feeling yet. Maybe in some places, but it's uneven. But we're going to get there. And I think when that happens, it will no longer feel like, ooh, are we being replaced? Or is like, are they taking all the value through AI? It's not going to be that. It's going to feel magical, and we're going to be safer, higher quality, and be able to do way more for patients and families than we can now.
Thanks, Rebecca. Justin?
Rebecca, that's so awesome. And I love the car example. I think as maybe one of, if not the only physician who's worked in the autonomous vehicle industry, actually basically wrote a piece on that and how healthcare should be shooting for what they call level 2 automation and augmentation for physicians and provider workflows. And that's exactly where we get the most excited. And I think there's tons of business models to create. And again, I love the question and the ambition to completely, destroy the provider payer relationship and reimagine healthcare. I think today I would urge people to focus on working within the existing systems and create, AI workflows that feel like magic to the people you're working with, which I think really is possible today. And work within the existing system, and then eventually keep improving that over time. And so I think that would be, again, just if you're thinking about AI business models or starting a company, think about who am I going to get money from? How does this fit within the existing system and incentives today? And then if it's an AI solution, how can I launch something that works today and augments? I get enough training data to eventually completely go from 0 to 100%. I'm much more excited about companies that can augment and deploy a solution today that is helpful, keeps a provider or someone in the loop, and then can improve over time.
Thanks, Justin. Lisa?
So Justin stole my takeaway. That was basically it. Yeah, having been a startup operator, and now being at a health system, I just think that we talk a lot about disruption in the market, and especially with, the crazy funding year that we saw, and now moving into different economic times. But I don't think about it as disruption. I think there's a role for all of these pieces of the pie. And yes, the system needs to be rebuilt eventually, but I can't see a future to that right now. I just feel like there's a role for all of us to play, and we need to figure out how, at Stanford and at health systems, I think in general, there's this phrase like everyone operating at the top of their license, and it's usually talking about the care team, but I think about it as the whole ecosystem. And so, how can we work together and be really clear, as Chris put it, about like, who is the customer, who's the payer, and what are the needs, and really being crisp about the needs assessment and to figure it out. So I think it's going to take a lot more collaboration, but I'm pretty optimistic, even though the days, the days are long, can make you pretty cynical, and it's always feels like a steep hill to climb. But I'm pretty optimistic that and maybe this is a little bit of a hot take, but I think this economic slowdown that we're heading into is going to be good. I think it's going to force a lot of us to go back to, basics and first principles. And, there was a lot of spaghetti on the wall and noise last year. I guess being on the buy side, it was just really hard to make sense of it all. And so I think I'm optimistic about the next several years.
And Chris?
Well, I I hate to close down with what I'm sure will be perceived as being an apologist of health systems and health plans, but I'll answer a question that you said in the chat, Ron, which is it was something to the tune of like, how do we navigate health systems and health payers, and how will they ever be aligned? Does the payer win out? And I would just say I actually think that there are business models that work for both, where digital health companies can go to health systems and healthcare providers. And actually, we've seen ones where the digital health company comes and creates net new value and brings both to the table. And I would say most digital health companies today are doing what is slightly easier, which is going to the payer. They're the at-risk entity. If you follow the dollar, you usually end up with the payer. But I think the time when you run into problems is when you try to sell a health system business model into a health payer, or vice versa. And so I would just leave this group by saying, like, you can definitely do both. Those exist today, and those two parties aren't always antagonistic. We work with Anthem, all the time. There's a lot of shared decision making, and both parties act as rational actors given the incentives that we put in place today. So know that when you build the business model.
Thanks, Chris. Well, we're at time, and so thank you so much, all of you, for joining us. Thank you for the conference organizers, and most of all, thanks to the audience, the members who was willing to spend the last 90 minutes with us. And I really think this was a very enlightening discussion. I think in particular because of the uncertain times but bright future, this is exactly why we need to have conversations like the one we just had, and I'm sure we'll continue to have more. Thank you very much.
Thank you.